score on the final exam, and it's happened before. Um, so let's see. This will be posted, by the way, this slide presentation, and of course, you'll have the recording of it. So I would highly recommend that you pay attention and review it, and you should do fine. Okay, the study guide for the final exams in Module 10, it just lists some topics. So this is much more helpful to you, I'm sure. I made it in a Word document. If you want to download it, you can type your notes in. This review today will cover nearly every topic that's on the final exam, so pay attention. I actually think I did cover everything. I went through the exam today and looked and made sure I mentioned something about each question, okay? So first of all, we're going to review ethical principles. And by the way, sometimes you'll see red circles around some of these things, and that means they definitely will be on the final exam. But there are almost every slide here might have something on the final exam. I just didn't put circles around everything. I'd started and I thought, oh, there's no point in putting circles around everything. But if you do see the red circles, they are definitely on the final exam. Most everything else is too. So autonomy, you need to know the definition of autonomy or recognize it. And it's certainly the right to refuse treatment. If somebody doesn't want to take their pills, if they don't want to have a procedure done, if they don't want to stay in the hospital, that is their right as long as they're of legal capacity. If they're not, they don't have dementia, severe dementia, or they're not confused or altered mental state for some reason. And remember, mental health patients, if somebody is there for a mental health issue, they still have legal capacity unless they're going through some psychotic episode or they are high on drugs or alcohol, where they can't make their own decisions at that point in time. So otherwise, they have the right to refuse whatever they want to refuse. Beneficence, remember, we do what benefits the client, what's good for the client. Think of benefit to the client, doing the right thing for the client, acting with compassion, positive actions to help others. Again, acting with compassion, just if you're showing the client and the families that you do care, you're talking nicely to them, keeping them updated, not trying to terrorize them with terror stories, horror stories of what could happen or whatever. And the example is calling a family of a client to tell them their loved one's critically ill and we're taking care of your needs. You might want to come into the hospital now. Reassuring loved ones is promoting good and acting with compassion. Okay, the next one's non-malfeasance. Remember, do no bad, non-mal, no bad. Don't do any harm to any patients. Avoid causing any harm or injury. Be the best nurse you can be. Checking drug dosages with another nurse as an example to avoid a med error. I'm just being very careful that you read the doctor's orders well and you do everything right. Okay, and then veracity. I don't know why people miss this, but I guess just hard to remember, but it just means veracity. Be very honest. Show veracity. Okay, very honest. Tell the truth, the whole truth, and nothing but the truth. Okay. If you don't tell the whole truth, you've violated this. If you don't admit something you did wrong, you've violated this. If you omit critical relevant facts to what you're documenting or telling someone, or if you cloak the truth in medical jargon so patients and families don't understand, that's not veracity, okay? Example is if you made a med error, the patient didn't have any adverse effects, but you still did report it because it was an error. That's showing veracity, okay? Next, about ethical principles, fidelity. Again, that means faithful, stay loyal to your clients. Justice, think of justice for all. We treat everybody fairly and equally. Okay, if we have a nursing shortage, we put the most nurses where the patients are most critical, where they're needed most. We try to be fair about it. Okay, and then advocacy. This is one that you may see on ATI and you may see on NCLEX. And NCLEX is big about seeing, does a nurse know she needs to be a patient advocate? And how do you do that? Usually the questions about being an advocate involve an elderly person. So I put example, an older adult client who has no family, they're uncertain about moving to assisted living, maybe the social worker came up and said, hey, we could move you into an assisted living facility or whatever. They don't know what to do. They don't have family to help them make the decision. So if the nurse helps him make the decision, she's acting as an advocate for him. You're helping protect the client's rights and their health and their safety. You're being an advocate for them. Another example is reporting critical changes in the client's condition to the doctor. There's been a change, so call the doctor, be the advocate for the patient. I want them to get better. I don't want things to get worse. Advocating for further treatment and analysis. Another example is end of life issues, access to health care, protecting client privacy, making sure everyone's adhering to standards of practice, questioning any orders that don't seem right, ensuring informed consent by the client. You're protecting the client, you're being their advocate. So know that. Okay, and then here's our pictures of the student nurses again with their Ohio State and Indiana State scrubs on, and they have a stethoscope around their neck because you need to realize what comes from the State Board of Nursing. So this all goes together. State Board of Nursing, Nurse Practice Act comes from the State Board of Nursing. And remember, these nurses are practicing nursing. They better not act up. So the Nurse Practice Act comes from the State Board of Nursing. They're in their state scrubs. They have their stethoscope around them because this defines our scope of practice, what you're allowed to do as an RN. This is your State Board of Nursing, your scope of practice. Again, you can think they're practicing nursing. They got a stethoscope around their neck that came from the state board, that scope of practice. So these are nurses practicing. They better not act up. So the State Board of Nursing, remember, they're responsible for your educational standards. They tell OMCC what courses you need to take, how many hours, and what topics need to be covered. And the school has to be, certified through them. Protects titles of RNs and LPNs. You have to have a license to call yourself an RN or an LPN, and they determine what your licensure requirements are. They define your scope of practice. It's defined by the Nurse Practice Act. Okay, that tells you what your scope of practice is. So think again of these nursing stethoscope. And remember, your Nurse Practice Act defines your scope of practice, defines the scope of practice. It deals with misconduct. It can discipline how you act. They deal with if you did something wrong. We talked about Redonda Vaught, and how she accidentally killed a patient. And they dealt with that. They took her license and they fined her $3,000. Okay, so remember what that is. And then a nurse has a legal duty to abide by the scope of practice in the state's Nurse Practice Act. True or false? It, of course, is true. Okay. Each state Nurses Practice Act defines the scope of activities that constitute the duty of a nurse licensed in that state. They're the ones who tell you that you have to abide by their scope of practice. That's in their Nurse Practice Act. Okay. A nurse has a legal duty to carry out the provider's written orders, whether they agree with them or not. Put your answer in the chat box, true or false. Put A or B, or put true or false. You do have the legal duty to carry out the provider's written orders, whether you agree with them or not. Is that true or is that false? Okay, good job. Yes, it's false. Nurses should question orders they disagree with and never carry out an order that they believe will harm the client. This can include medication orders, treatment orders, discharge orders, etc. So if you question the order, and the doctor still says they want it done, then you go up the chain of command and to your nurse supervisor and say, I'm not comfortable doing this. I've clarified it with him. He still wants this done. I don't feel this is in the client's best interest. Could you pass this assignment to someone else, or could you decide if the doctor needs to be called by you or whatever? So don't carry out any orders you don't believe in if the doctor's explained it to you and you still don't believe it. So that is right. Okay, and then remember this lady that looks so professional here in her black scrubs and her white coat. So this nurse is standing firm on her ethics, okay, and she looks professional in her lab coat. So you just have to remember this whole picture. And remember, she's standing on one foot here. She's practicing standing on this one foot, and she's standing on this word ethics that these other nurses are holding up. So now that you've got the picture, then you think she's professional. So this represents the professional nursing organizations and what they're responsible for. They're responsible for our standards of practice. Okay. So take a stand, and she's standing on these ethics, and they're responsible for our code of ethics. So she's standing on her ethics, principles of conduct. Also note that the many hands that are holding up the letters for ethics, remember it measures you against what another prudent nurse would do in the same or similar circumstance if you're taken into a court of law. They're going to pull it from your professional organizations. They'll go to the ANA or something like that, and they'll want to see the code of ethics. Did you follow those? Is that what is expected of a nurse in your position? Okay, so remember that your professional organizations are responsible for your standards of practice. She's practicing standing on the one foot, and code of ethics. And remember the word ethics being here. So that's who's responsible for those two items, the professional organizations like the ANA. And then this last one, the P&P, the pee and poop in the bedpan here. This nurse is at her facility in her funny little nursing cap here. She's caring for her clients by taking care, dealing with their pee and poop. And so remember caring. The standard of care is from your facility where you work, your hospital, your facility, their policies and their procedures, their P&Ps, their P's and poops, caring and policies and procedures from your facility. So remember that is how I came up with remember where that came from. Okay, so hospital or facility, wherever you work, they have policies and procedures, and they're responsible for your standard of care. That tells you how to care for your clients. It's according to their standards of care, and you can find them in the policies and procedures at your facilities. Okay, next, what does the OBN, the Ohio Board of Nursing, determine regarding nurses? So if you get a question like this that lists all these things, you need to know who's responsible for each of these. So standards of practice, remember that nurse standing on her one foot, practicing standing on the one foot. She was from the professional organization. She looked so professional. So that standards of practice come from the professional organizations like the ANA. The question was about what would the Board of Nursing be responsible for? Our scope of practice. Remember the stethoscopes around those student nurses that are practicing nursing comes from the State Board of Nursing. The Nurse Practice Act. Now, we talked about standards of practice. This nurse was standing on a foot, balancing. She was from the ANA. Standards, where are we? Okay, standards of care. Oh, wait, no, Nurse Practice Act, because we got some of the same words, so that's what I'm trying to tell you. Nurse Practice Act. Again, we have our practicing student nurses. That comes from the State Board of Nursing. And then standard of care, not standard of practice, standard of care. The care was at the facility. That woman had her pee and poop, remember? Policies and procedures, standard of care, where she cares for her clients at the healthcare facility. And then back to the Ohio Board of Nursing or whatever Board of Nursing you're in. They're responsible for your educational standards. Think of school boards and boards of nursing. Then your ethical standards. Again, remember the word ethics under that professional looking nurse that was standing on one foot on the word ethics, that she came from the ANA, the professional organization. Policies and procedures, the P&P, that's where your standard of care, remember from where you work, okay, comes from. And then who disciplines nurses that are working impaired? It's your Board of Nursing, okay? You better not act up, remember? Okay, so just recognize where each of those come from. Okay, now we're going to talk about torts. We'll take a break at about 3:30. Okay, so we'll keep going here for a little bit. Unintentional torts, negligence. You didn't mean to do this, but somehow you didn't do something you should have done. Failure to provide adequate care that another prudent person would do. Examples would be failure to report important changes in condition of patient in a timely manner, like you saw that they didn't have a pulse, in an extremity, that they have a cast on, and you didn't notify the doctor until like the end of your shift or something. You need to do it right away before anything bad happens, okay? Or a daughter advised the nurse not to tell her dad that he has cancer, but he's alert oriented. There's no reason, and he didn't give his permission um, that she could hold secrets or anything. But anyway, um, so he didn't consent to have his daughter make his decisions. And if you withheld that information, that's a negligence, okay, an unintentional tort. Or a nurse that did not wash his hands before inserting a Foley catheter, that's negligence. That's didn't follow procedures and take care of the client the way they should. It's carelessness too. Um, a fall by a patient being watched by a sitter. They fell when they were supposed to be have a sitter watching them. Excuse me. That's all negligence. Okay. And now we have unintentional towards another one, negligence, and now malpractice, professional negligence. Okay. Now this is something that you've done that causes damage. You did something negligent, caused damage, and you have a license. You're a licensed person like a doctor, a nurse, an LPN, a respiratory therapist, whatever. So, whoops. Back it up because I didn't finish that one. I was thinking I had a circle around that. So illegal, improper, or negligent actions by a licensed personnel that causes provable damage. Okay, you didn't follow your standards of care. Example, a nurse failed to check dosages on a medication vial and it harmed the patient. Or like LaDonda Vaught, she didn't even check that it was the proper medication on that medication vial. The nurse broke sterile procedure while inserting a Foley catheter, and the patient got urosepsis from it. They had a really bad urinary tract infection that turned into sepsis. Okay, so the next one, again, I circled it to know the difference between assault and battery. Just because a question might say, this patient was going to leave the facility, so you put restraints on them. What did you do there? They threatened that they're going to leave the facility, so you just went ahead and restrained them. What is that? Is that assault or battery or both? Anybody? It's battery.
Battery.
Yes, thank you. You touched him, but if you threatened first, if you said, "I'm going to put restraints on you if you threaten to leave one more time," then that's assault. And then if you said, "I'm going to put restraints on you if you leave one more time," and then you do it, that's assault and battery. So remember, assault comes first. Usually it's a threat, but you don't always have to have a threat before you do the battery part. The battery is harm or just touching someone or doing something to them they don't want done. That is considered battery. So a threat of harm, any threat made toward a client, I'm going to restrain you if you keep getting up. If you don't give me a urine sample for a drug test, I'm going to stick a catheter in you. Battery, physical act that causes harm, or unconsenting contact that causes harm, or just that they don't want that contact done. Performing a procedure without consent, giving them medication that they refuse.
So I was about to say, so giving the medication wouldn't be assault?
If you don't threaten, no. If you just say, "Hey, I'm coming on its third shift here. They're not sleeping well. I'm going to give them their sleeping medication, even that's ordered PRN, even though they didn't ask for it, because then I'll have a better night." So you give them their sleeping pill, and maybe then they say afterwards, "What was that?" And you say, "Oh, that's just something to help you relax." "Well, I didn't want that," whatever. Anyway, that's battery, because it's not assault. You didn't threaten to do something to them. It's just battery that you went ahead and did something that they did not consent to, and that in this case they did not want. Okay, does that make sense?
Yes, it do.
Okay, just as if you didn't make a threat but you went ahead and did something, it's just battery. But if you threatened them and then did something, it's assault and battery. Okay, and then chemically restraining a patient, which is the example I just gave. Giving a medication that they refuse, also that one could be. Maybe they didn't want some shot and you held them down and did it. Okay, so battery. Okay, and this one is torts then. Intentional torts, willful acts that violate a patient's right. And again, that's the assault, threatening things, battery, actually doing something they don't want done or hurting them or whatever. And then we can have false imprisonment, and we could have all three, So false imprisonment is if you have restrained someone against their will. Now, again, we do have psychiatric holds that we can do this. Someone who is a threat to themselves and others, maybe they're high on drugs or something like that. Or they're psychotic. There are times that we could physically restrain someone, um, and and it's justified. But typically, not. So keep someone against their will using physical restraints or seclusion, putting them in a room, by themselves, not letting them out or whatever. Chemical restraints, giving them a sedative or sleeping pill or some kind of medication that's going to put them out or make them sleep and or calm them down so that they didn't want. Example, using restraints on a competent client to prevent their leaving the healthcare facility. And again, it doesn't apply to some people, but and now if we've threatened that we're going to do it and we go ahead and do it, and they wanted to leave, okay, then we've done all three. We've assaulted them because we've threatened we're going to do this if they leave the facility, and we've done it. We've restrained them against their wishes. And then that's also false imprisonment because they don't have the ability to get up and leave because they wanted to. So we've got all three going on there. So assault, battery, and then the quasi-intentional tort of invasion of privacy, breach of confidentiality. So yes, a breach of HIPAA, that's the example, ultimately, violating confidentiality rights. So if you violated HIPAA laws and not, again, it's not just saying somebody's name or something, but if you've got any medical information you're given about this patient with their name or without their name even, then that is a breach of confidentiality, and that's a quasi-intentional tort. Okay, we're going to go ahead. Okay, so we were talking about assault, battery, false imprisonment, which are intentional torts, and the quasi, however you want to say it, quasi-intentional torts, which are kind of sort of torts, in other words, is if you have an invasion of privacy, a HIPAA violation, because sometimes that's not intentional. It just kind of happens by accident, but it still is a tort. You've still done something not appropriate and not right. You can still get fired for it. You can still lose your nursing license for it, depending on how bad it is. Okay, so now another tort, quasi-intentional, besides the invasion of privacy, breach of confidentiality, which is a HIPAA violation. Now we've got defamation of character. And that's when you make rude, insulting remarks that harm a client's reputation. It can also apply to coworkers. So you could make it about a client, you could make it about a physician, you could make it about another person that works at your facility, whatever. If you're saying something, you're spreading gossip, you're talking or saying something bad about them. So it's spoken and it's slander. If it's in writing, you've typed an email to somebody or posted it, online or social media, or sent a text to somebody, or written it down for some reason, it's libel if it's written down. So think of library, everything's written in books, it's libel. And S for slander, or slipped out of my mouth, or spoken, slander spoken. Okay, so we have our intentional torts. We talked about negligence, failure to provide adequate care, malpractice, you failed to provide adequate care and you injured the person. Quasi-intentional, they're sort of intentional, maybe, breach of confidentiality, HIPAA violation, defamation of character, slander or libel. And now we have intentional ones, which we talked about. Assault is threatening injury or threatening to perform something somebody doesn't want done to them. Battery is if you actually have physical contact or you've done something offensive without their permission, like if you've given them a pill or medication, we're considering that physical contact also. Or false imprisonment. If you've confined them to a room or an area or restrained them against their will, it's false imprisonment. Okay, now ethics committee. This is one that people tend to get wrong on the test, even though I stress it, just like the Good Samaritan one, we'll go over that too, that I stress and people still get it wrong. So ethics committee, pay attention. The ethics committees of healthcare facilities, they're there to help you. They're not there to make all the decisions for you or anything like that. They're just there somebody to talk to. Okay, just remember that. So they provide guidelines and recommendations for potential issues. They're not going to make you do what they say. They're not going to do it for you either. They're just giving you a recommendation or some guidelines. They might remind you what some hospital policies are. They always want to keep the patient at the center of whatever they suggest. They serve as an open forum for discussion, function as patient advocates by placing the patient at the core of their committee's decisions. They do not impose decisions. They don't tell you what to do. Okay. They promote patients' rights, the rights of patients. They promote shared decision making between patients and their healthcare providers. They want you with your patient and with their doctor and everybody to make the decisions yourself. Okay. They promote fair and equitable policies and procedures that work on achieving quality patient centered care. They enhance the ethical environment of healthcare professions and healthcare institutes. They just help remind you, what might be legal and not, and what is best for the patient, or what the patient's rights are. Okay. Um, Points to remember, they are not your first option. If you have an ethical dilemma with a patient, your first option is not to run to the ethics committee. They are not your first option. They're just an additional resource for clients and healthcare professionals if you can't resolve it yourself with the client. Okay. They do not replace decision making by clients or the nurses. You can't just go to them and say, I just can't decide this. So, and they'll say, okay, we'll take care of it. No, they don't take care of it. They don't replace you taking care of it yourself. They do not relieve nurses from dealing with the ethical issues. Remember, they're not your first option to go to. They are additional resource. They don't replace the client making the decisions and the nurses helping them or whatever. And they don't relieve you from dealing with that ethical issue that you're trying to decide. Okay. Now the Good Samaritan Law, another one that people get wrong on the final exam and the midterm. I think I had it on there too, but I can't remember. Um, but Good Samaritan laws protect and encourage people, including nurses, to provide aid in the event of an emergency. You're out in the community, you're outside of your work environment. Okay. And without fear of being held liable for their well-intentioned actions. But the nurse is not obligated to provide care for anyone outside of their employment obligations. Don't get tricked by somebody saying, because you've got a license as a registered nurse and you work in the ER or whatever, you're in EMT, whatever, you're required to take care of this patient. But the Good Sam Act, the Good Samaritan Act protects you. That's wrong. The Good Samaritan Act does protect me, but I'm not required to take care of them. So that whole statement is wrong then, because I am not required to take care of a person just because I have a license if I don't work, if they're not in the facility for where I'm working. Okay. If you do decide to help them, try to obtain permission, perform reasonable behavior, don't work with outside the scope of your practice or do something that you're not supposed to be doing. Nurse must continue care until they can be turned over to the EMS, or it's going to be abandonment too. You have to stay there with them. The nurse will not be protected if care is rendered without due care or disregard of safety for the individual's gross negligent care. Okay. Or if you know about their medical condition, you've been doing an assessment on them, asking all these details and their medicines and everything. Now you're kind of assuming them as your patient. And so you're not protected by Good Samaritan Act if you do that. Or if you take any compensation, even if they give you like a gift card to a restaurant, no, then you're not protected if something goes wrong. They can come back at you and say, well, she took payment for it. She got compensation for it. I gave her a gift card. So you're not protected by Good Samaritan Act in that case. But remember, you are not obligated to provide care for anyone outside your employment obligations. Okay. So a nurse has a legal duty to provide Good Samaritan care at the site of an accident. False. Okay. But nurses are protected, from legal liability if you do provide care. Okay. Avoiding liability for negligence. Follow your standards of care in your facility. Give competent care. If you don't know how to do something, don't do it. Go tell somebody, I'm not comfortable doing this. I haven't
Please
done
go back
it.
to the last slide.
Pardon?
Just the last slide.
Or the last slide? This one?
Yes.
Did you have a
Okay,
question
thank you.
about?
No, I'm done. Thank you.
Okay, I am going to post these slides, by the way. You don't have to take screenshots unless you want to. Okay, avoiding liability, again, make sure you follow your facility's policies, standards of care, that you're giving competent care. If you don't know how to do something, don't do it. Get some help. You know, tell somebody, I haven't done this since nursing school, or they didn't teach me this in nursing school. Can you help me out with this? Communicate with other health team members, you know, to help the patient out, to do the best you can for your patient. Develop a caring rapport with the patients. You know, be sincere. I hope that you are in nursing because you really do, care about people, and you do want to do your very best, and you do want to help them. So develop that caring rapport with them. Show them that you really do care, and fully document any assessments you've done. If you don't document an assessment you've done, that record is not accurate. If you've falsified records because you've left out something that should be in there, you should document all the interventions you've done, any shots you've given, any wound care you've done, anything like that. If you don't, you've falsified records if you don't document it, because you're not documenting any assessments, interventions, and any evaluations. You gave them a pain shot, and you might have gone back, 15, 20 minutes later and said, how did it work? Are you feeling better? Yeah, it's working now. And you don't document it, then that's falsification of records, okay? So you must document fully any assessment, any interventions, and any evaluations you've made on clients. Avoid liability this way. Fully document. Okay, now, 5 elements necessary. We went through this to prove negligence. And the big thing was example about a patient who's at a fall risk. The nurse should complete a fall risk assessment for all clients during admission. And if you don't do that, it could deteriorate quickly. They could get up and they could fall because you haven't done your assessment, and you're responsible. And if you remember this chart we went through talking about how to prove liability, the court goes through this. Did you have a responsibility to do it? Yes, you did. Did you breach that responsibility? Yeah, if you don't perform the fall risk assessment, you've breached that. Did you know that the patient could be harmed if you didn't do what you were supposed to do? Yes, you should know that. And then, did they cause harm? Well, if the patient falls then and hurts themselves and breaks their hip or whatever, then yes, harm has occurred. And you will be in big trouble then. So that's negligence, to prove negligence. This is documentation to verify that it was done. You need to make sure that you do complete a fall risk assessment and document it during admission. Okay, so this was a question from Manclex. A nurse has been named in a lawsuit. The best evidence the nurse should use for self-protection in a court of law is to document the nursing actions. Remember, any assessments you make, any interventions you make, any evaluations you make, document what happened in the client's records. It doesn't matter if you're certified in emergency nursing. That doesn't show that you're a good nurse. If you have good proficiency reports by your nurse manager, they say you're a good nurse. It doesn't matter if you get called into a court of law if you didn't document something that you were supposed to do or that you did, and you can't prove it. Verification of orders from the plan of care on a daily basis, that's a good thing to do. But again, it doesn't prove anything in a court of law about how you took care of your patient. Your documentation will. Documentation is key for a nurse to be protected legally. Documentation should include all pertinent data with times, dosages, sites of actions, collected data, the nurse's response to any change in the client's condition, specific actions taken, and other healthcare team members were notified. If they were, make sure you document that. Responses or outcomes, what they were. So thorough documentation. So what's the answer for this? The nurse checks the client's level of pain, but doesn't document the findings. Is this an example of falsification of health records? Yes or no?
Yes.
Yes, correct. Okay, good. It's falsification of records because something is omitted from the documentation that should be there. Okay. So it might think that, oh, I just forgot to document it. I didn't falsify a record. I didn't write something wrong. No, but it's not an accurate record because you didn't put what should have been in there. So it is an example of falsification of health records because it doesn't include the documentation that it needs. Okay, advanced directives now. Advanced directives, remember legal documents that outline the desired medical care treatment if the client becomes unable to verbalize their wishes. And again, it's not that you write this down and that's the way they have to do it every time you go to the hospital. No, as long as you're alert and oriented, you tell the doctor, oh, yes, I want to be revived. Yes, I want this medicine. Yes, I want to do whatever. But if you're unable to make your own decisions because you're unconscious or something like that, or you've now gotten severe dementia or whatever, if you can't verbalize your wishes, you've got this written down. It's not a final will that deals with property or your money or anything like that. It's living will. It's advanced directives. It talks about what kind of medical treatment you want. Okay. Documentation should be placed in the client's medical records. Give copies to your friends and families, anybody that might show up at the hospital if you're sick or injured, and let them know to bring that with them. You know, anybody that you list as your healthcare proxy, that they can make decisions for me, make sure they have a copy. And the big thing is, don't lock it away where people can't get to it. Don't put it in a safety deposit box at a bank. Don't put it in a safe at your house. Have it ready at your house so that it's there when you need it and the EMS come to pick you up, over ambulance or something. Or even if you're getting in the car to go, grab that, have it where you can get to it. So if you hear a statement or see a statement on a test that says, what's something that's concerning that the patient tells you, if they say, oh, don't worry, I locked it up in my safety deposit box at the bank. Well, that's concerning because you're not going to get to it. Another thing to be concerned about is if they say, oh, I've got one, but I haven't brought it in because it's not notarized. It doesn't have to be notarized. It says right here, does not have to be notarized. So let them know that no, it doesn't have to be notarized. It's still okay as long as we have two witnesses that are not your nurses that are directly involved in your care or your healthcare provider or anybody directly involved in your care, or not somebody that you designated as your healthcare proxy. So again, it can be anybody else though that can just sign it saying, yep, I saw that this is yours and this is what you want. If there isn't any advanced directive found, then we have to do full treatment, full code, full life-saving measures. I don't care if they say, we plan to do this. The doctor knows I told the doctor what I want, but he hasn't signed it yet. Until he signs that, and puts it in your chart, then it doesn't matter. It's not complete. Okay. Doctors don't always have to sign it, but if it's something like that, yeah, I have it. I haven't signed it yet. The social worker is going to bring it to me to my room here in a little bit, and so we know that that's what she wants, but she hasn't signed it yet. If she codes before that's it, she doesn't have it legally in place. So we would have to do full life-saving measures. Okay. And remember, it does not have to be notarized. Don't lock it up in a safety deposit box. Okay. So types of advanced directives, durable power of attorney. If it's just a power of attorney, that usually means somebody has the legal right to sign for your financial decisions and your property and things like that. But for medical purposes, it has to have the D in front of it. So think about a doctor or something for medical, but it's called a durable power of attorney. And that's who can make decisions for you, who can make healthcare decisions for you. A living will is what you have written out that you want done, what type of care is desired, your living will. And then portable orders are kind of what they say. You carry them around with you. They're portable. So it can be one of those do not resuscitate wrist bracelets or necklace, or the pulse. Remember that physician order that was a little piece of paper that the physician writes orders on. And that's a lot of times for people that are in chemotherapy or some life-saving end-of-life type things that they might change it occasionally. So they have these orders they carry with them that might change occasionally, but those are portable orders. Okay, now HIPAA. Know what are not violations of HIPAA. Okay, did I circle this? I circled the whole thing. Okay. You can't control what visitors say in the waiting room. So if some patient shared with them what was going on and that patient left, went back to see the doctor, and the other people that are waiting in the waiting room are talking about them, saying, oh, he said that he has this, that, and the other, and oh yeah, that's awful, whatever. You can't control that. Don't, that doesn't have anything to do with you, so don't worry about it. It's not a HIPAA violation. You can't control or be responsible for the roommate hearing details from reporter conversations about their care. So if you're in a patient's room and there's no other way, you're going to be talking to them. It's not convenient to move the patient out or the roommate out of the room. You just pull the curtain. We call it the magic curtain. Yes, I know the client their roommate can hear through the curtain, but because you pulled that curtain and you're talking to the client, it's known that what you're talking to the client is personal information, and the roommate is probably going to hear it. But you can't be responsible for the roommate of a patient hearing details from report, like if you're giving report to another nurse in the room, or conversations with the client about their care. That is not considered a HIPAA violation. Okay, it is not. And that's where people get that wrong sometimes on tests. Calling out a patient's full name in the waiting room, that's fine. Again, that's not HIPAA. HIPAA is about my medical issues, Um, writing the patient's last name on a whiteboard, that's fine. If they write it on the whiteboard and put hysterectomy after it, they're putting what my procedure is going to be or something. That's violating my privacy if, family and friends walking around can see that whiteboard. But if it's just my name, it can be my full name. It doesn't have to just be my last name, but it doesn't violate my privacy, my HIPAA privacy. Telling a visitor to wear a mask because the patient's in isolation, that's okay, but don't tell them what their diagnosis is. That's DX stands for diagnosis, or any details about it. Okay, well, it's a respiratory issue. No, don't even tell them that. Just say, this is what we're requiring because they're in isolation. If you want to know the specifics, you'll have to ask, the patient. Inadvertently sharing of data is not a violation of HIPAA as long as the nurse can use reasonable measures to protect the patient's information. So maybe she's sitting at the desk talking to the physician and they're showing them something from the chart and they turn around and somebody's over their shoulder, visitor looking at the chart over your shoulder. You couldn't help that. That's not considered a HIPAA violation. You did take measures, you were behind the nurse's desk and everything, so people couldn't hear. Anyway, giving a
Miss
patient,
Brenda,
yes.
can you go over the one before it says the general discussions about care for
Oh,
disease?
sure. So let's say your loved one has HIV and he's, in some room and you happen to walk by the nurse's station and the nurses are, let's say they're talking about, they said, did you hear that they're working on a vaccination for HIV? It's not approved. This is true, by the way. It's not approved yet, but they are working on a vaccination to prevent HIV. And this patient hears that. That's not a HIPAA violation because I'm not talking about that client. I'm not mentioning their name. I'm not saying, oh, we have a patient here that has HIV and he did this. Now that would be a violation. But if I'm just talking about a disease and something about it without regard to a specific patient, even if I didn't mention, again, then that's not a HIPAA violation. We're just talking about the disease itself. But if I say, not even saying the patient's name, and if I say, we have a patient here that has this disease and blah, 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 then that could be a violation because we're talking about someone specific, even if we're not mentioning the name. And I gave you an example before of what happened to some nurses at the Valley and in the elevator. They were talking and laughing about something going on with a patient that was very specific, even though they didn't mention any names or anything, but it was very specific, unusual thing that happened to this patient. And there was a family member in there, and those nurses got fired because they said, no, it was identifiable because of what you were talking about. So, okay, did that
Thank
kind of,
you.
uh, and then giving a patient's healthcare information to another facility, as long as we have the patient's permission, yes, we can phone a report, tell the other nurse, we've got a patient coming to you, and the doctor can talk to the doctor with the report. We can fax information as long as the patient has agreed to that and they agree in writing. And sometimes we even at the hospital, we'd call our report, we put all their medical records in an envelope, give it to the patient. And even though they went by EMS, they they held that record and took it to the next facility they were going to, and gave it to them there. Okay. Husband of a client requesting lab results for his wife. How should the nurse respond? Let me check to see if you have permission. Okay. Even though she might have been introduced to him 2 days ago and he's been in and out constantly, if she hasn't looked to see if he has permission yet, then she needs to say, let me check and see if you have permission. And if they don't have permission, then she needs to say, let me get permission from, you're not listed. Let me go to your wife and see if I have permission to give that information to you or something. So don't read more into the question I put. The simple answer for this is, and any other similar situation is, you need to check to see if he has permission before you give lab results. And if he doesn't, then you have to ask the patient if you can release that, or you can just tell them, well, we don't have permission listed here until she can give us permission. I can't share that information, but you say it nicely or however you can. Okay. The client's wife is asking for more information on her husband's condition since he returned from the CAT scan. Again, get permission from the client before giving any information to the wife. So maybe you checked and you say, oh, she's not listed. So say, let me go get permission from him, to see if we can share that information with you. So don't share the client's information with anyone outside of immediate healthcare team at the facility where he's a patient, even his wife, without getting permission. More on HIPAA, the nurse would be justified in breaking confidentiality, select all that apply, and it's these first two. An older adult client disclosed their caregiver hits them. You are a mandated reporter for elder abuse. Typically, it's considered 65 and older, but if it's also an impaired adult, somebody with maybe mental disability, dementia, Down syndrome, something like that, that are considered vulnerable, population, you're mandated reporters for those. A client states he's going to go to his neighbor's house and open fire because the neighbor stole his OxyContin prescribed for his recent left knee replacement surgery when the neighbor visited him. Yes, you can break confidentiality, then you will notify the police, okay? Notify the police immediately. And again, if a 19-year-old pregnant woman, first of all, she's 19, so we don't want to share her information with anybody. It says her boyfriend, who's been overseas for 5 months, will break up with her if she finds out she's 3 months pregnant. She doesn't want to disclose that. No, you don't disclose it. Keep it confidential. And then here was an example of a boyfriend of a client. She delivered a baby. Doesn't matter how old she is. But anyway, but the boyfriend wants to know the baby's blood type because he says he wants to make sure he's the father. So first of all, no, he can't have the baby's blood type. He can't even prove he's the father. He says he thinks he might not be. So anyway, according to the question, he doesn't even know if he's the baby's father. So he does not have the right to know the baby's blood type, or at least not from the nurse. He could get that from the client if he wants. And remember, it is a HIPAA violation to give lab work like drug and alcohol results to a police officer, they ask. We saw this in the ER all the time. The police officer would order it. He could do that. He could request, that we get and they wanted it as soon as possible before the alcohol wore off or the drug wore off or anything. And we would, do that. We'd draw as soon as possible. Then they always wanted us to kind of just let them know, is positive, or does it show he's, impaired, blah, blah. And I'd always say, I can't tell you that. Don't ask me and get me in trouble. You're the police, So they have to subpoena it if they want that information, okay? They have to go through the proper channels. So even giving it to a police officer, any information about what's their condition and what's their blood work look like, were they positive for alcohol and drugs? Can't tell you, Okay, it is a HIPAA violation to take home any medical information about a patient, like a shift change report sheet, even if it was an accident. You didn't do it on purpose. When you got home, you ripped it up and threw it away. It's still a HIPAA violation. You took home personal medical information about a patient, okay? And it should not have left the facility. And even if you tore it up, even if you shredded it, it doesn't count. So these are HIPAA violations. Okay, And again, about HIPAA, 19-year-old female, so put your answer in the chat box. Ask for a prescription for oral contraception. She's under her parents' insurance, but does not want her parents to know she's going to be taking the pill, birth control pill. But according to HIPAA, which of the following should the provider tell the patient? This information is kept private, so they will not know. Your parents may not view your medical records. However, since you're on their insurance plan, they may find out from your insurance billing receipts. Because you're under 21 years old, your parents may have access to your medical records if they ask. All medication pertaining to reproduction must be reported to parents of girls 21 years and under. And you guys are right. Yes, it's B. The rest of these are false. Okay. We can't promise to keep this. We're going to keep it private. We're not going to tell their parents or anything, but they probably will find out through their insurance billing receipts because she's on their insurance plan, and they have the ability to see what they're being charged for, or what their insurance is being charged for. So your parents may view your medical record. However, since you're on their insurance, they may not view your medical record, and we're not going to share any information with them. But since you're on their insurance plan, they may find out from their billing receipts. Okay. School nurse is called to the scene of a large fight that just ended. The school security officers have called the police. Which of the following actions should the nurse take first? And I put this here because you may see this on the test. Okay. Yes, always the patients first, triage the injured students first. Okay. That is the correct answer. School nurse should apply the nursing process priority setting framework to plan client care and prioritize nursing actions. And so the nurse should teach coping skills to the students. That was about this, who witnessed the fight. Yes, she can do that later, okay? Not her first step. What about providing support to help staff members deal with the traumatic situation? Again, she could do that later. Compare the response to incident with school policies. Yes, she'll probably want to do this, to see, but later, did we follow the policies of what happens if we see something violent going on, and did we respond appropriately? But the first thing she does is take care of the patient, triage the injured student. Just like the first thing that you do if you see the alarms go off on the cardiac monitor, the first thing you do if you hear the alarm going off on the ventilator, you go check the patient. Don't check the equipment, check the patient. Somebody has diabetic glucose monitor things, the automatic ones stuck in their abdomen. I can't think what you call them, those portable ones. But anyway, and it's beeping and everything. You don't start fiddling with the machine. You check the patient. Are they having a hypoglycemic reaction or anything like that? Are they okay? If they are, then you deal with the machinery. But anyway, always assess first, assess the client. Okay, signing out AMA, that means against medical advice. Again, remember the patients have autonomy. They have the right to refuse treatment. They have the right to refuse staying at the hospital as long as they're competent to do so. Right to refuse treatment, right to refuse medications or other therapies, even if the client was involuntarily admitted and has legal capacity, except for in an emergency situation. The right to refuse to stay in the hospital. They can choose to leave the hospital before proper discharge. And remember, AME means against medical advice. And medical staff must first, though, determine, do they have the right to leave? And if they're competent, they do. So was the client informed and properly educated of the risk of leaving? So you want to make sure you let them know, you could bleed out from this, or you could get an infection from this. If you leave, we'd rather you stay a little longer and let us treat it, whatever. Inform them of what could happen. What are the risks of leaving? And then, was the healthcare provider notified? This is important. We want to get a hold of the healthcare provider as soon as possible to see if they can talk to them or anything, and also for them to know what's going on. Are they competent to make the decision to leave? Are they under the influence, hearing voices, have some mental instability or anything? Do they have a legal hold on them where they, even if they are competent, if there's a legal hold, we still cannot let them leave. And NCLEX tip is, don't call security as your first option, or don't call them unless we find out they do have a legal hold or something. So one of your first actions is not to call security to get them to help. No, it's if they want to leave, just inform them of the risk of doing that and get a hold of the healthcare provider as soon as possible. This should be one of your first things, is contact the healthcare provider and inform the client what could happen. And then have the client sign an AMA form or document their refusal to sign it if they don't want to sign it. And then remove any IV catheters or tubes before they leave, of course. So this question illustrates this. Which of the following clients cannot be allowed to sign out AMA? Select all that apply. A client who believes she's Joan of Arc. She's delusional. People that are delusional cannot make their own decisions. We cannot allow this person to leave to sign out AMA. Okay. Somebody who's intoxicated and has been drinking heavily for 12 hours and can't even walk. They're so intoxicated. No, they're not safe for themselves or others. We cannot let them leave against medical advice. So we can hold them. What about the client who says their voices are telling him to kill his child? Yes, certainly he's a threat to others and he's hearing voices. So even if this last part wasn't here, if it's just the client who says he's hearing voices, we're not letting them leave yet. Okay. They're having hallucinations. Okay. Audible hallucinations. And then a man with a deep cut on his forearm, it's still bleeding. It needs stitches. He's aggravated. He's had to wait for so long, wants to leave AMA. We have to let him leave. Even if the man whose arm's bleeding is in danger of losing too much blood or causing further injury, he has the right to leave. There's no indication that he lacks legal capacity. So we would contact the doctor, the healthcare provider as soon as possible. We would tell him the risk of leaving, against medical advice. We'd try to get him to sign the form. And if he refuses to do that, we would just sign that he refused. And what time he left and everything, and what his condition was when he left. Okay. A client was admitted voluntarily for treatment of an anxiety disorder. He's now demanding to be released. What action should the nurse take? And the action that the proper answer is contact the client's primary healthcare provider. Okay, remember that's one of the first things you do, contact their primary healthcare provider. Yes, it would be the initial action the nurse would take. You don't restrain him. That would be battery and illegal imprisonment. You don't call security. He came in himself because he's having some anxiety disorder. Call the pharmacy department to rush his medication. No, again, not the initial reaction at all. First thing, notify the healthcare provider, explain to him what could happen if he leaves, what the risks are. Okay, now informed consent. Remember, if somebody's given permission for a procedure or surgery or anything like that, who can give consent? State law determines it, and they basically say anybody that's competent adult, parent or guardian of a minor, legal guardian, that's a representative, a healthcare surrogate if they have the power of attorney or proxy, a spouse or closest available relative if the patient's unable to give consent, or an emancipated minor, and that's down here. If a minor is pregnant or a minor is married or they're emancipated by the court, or if they're being treated for substance abuse or a sexually transmitted infection, they're considered emancipated in this case where we don't have to share their information with their parents. Members of the military that are minors and minors who are parents, okay? And then who cannot give informed consent? If somebody has an altered level of consciousness because they're not competent to provide consent. This could be from drugs, from a head injury, from alcohol, whatever. If they're unconscious, of course, they can't give us consent. Maybe they're unconscious because they're in surgery, and we're not going to wake them up from surgery because they're under the influence of the medications we gave them anyway, and you don't want to wake them up to get permission for something. Anyway, mental health. Again, if somebody's in for a mental health issue, they're still considered competent unless it's during an episode of bipolar schizophrenia, like the manic phase, or they have what I can't even think right. Anyway, clients with mental health issues, even those admitted involuntarily, still have the right to informed consent as long as they remain competent. They're not having a psychotic episode. That's what I was trying to think of. Or if somebody's impaired with alcohol and drugs, they can't give consent. If somebody has dementia. Now, if they say they had a history of dementia, but because maybe they had a TIA or something like that. It lasted a little longer. But anyway, but if they have dementia at this time, or if they're delirious, they're imagining things that aren't true, like that person that thinks she's Joan of Arc or Taylor Swift or somebody, okay, delirium, then they can't leave, okay, they can't give informed consent. Non-English speakers, they can't give informed consent unless they truly understand. So we need to have a medical interpreter to translate, not a family member or friend. And then again, a minor less than 18 years, they require a parent or guardian to give consent for them unless they fall into these categories. Okay, and so here's the question. A client needs emergency surgery, but they cannot sign the operative consent form because of sedation. We've already sedated them. The nurse should take what action? Obtain telephone consent from a family member witnessed by 2 authorized individuals. So we're going to call up, the spouse or family member, the parent or whatever, try to get a close relative, and get permission from them. And then I've heard it on the phone. I'm going to hand the phone over to somebody else, a doctor, another nurse or whatever, and they'll hear them given permission also, and we will both sign it then. We are not going to wake them up. They're under sedation. Okay. We're not going, they're still going to be under sedation even if we wake them. We're not going to sign it for them. We're not going to get the nursing supervisor or the manager to sign it. Nobody in the hospital can sign it. The doctors can't sign it. The president of the hospital can't sign it. Only the patient or one of their family members that are giving permission. Okay. Get a family member to give permission over the phone. Have 2 authorized individuals sign that they witnessed the consent. Here's another question about that. Informed consent can be provided by which of the following clients? A pregnant 16-year-old can give consent for herself, okay, because she's pregnant. So 16-year-old, if she's under 18 and pregnant, she can give consent for herself. 36 weeks gestation, painful vaginal bleeding. She's pregnant, can give informed consent. Spouse of a sedated client, yes. The spouse or close relative of a client, patient who's sedated can give informed consent. What about a 16-year-old? So they're underage, but do they meet the criteria for being emancipated? They need antipsychotic medication administered to them. That doesn't fall into the category. Remember, if they were being treated for a substance disorder or sexually transmitted infection, then they can give informed consent, but not for anything else. In this case, it's antipsychotic medication administered to him. And what about a non-English speaking, non-English understanding client? And I had this question before, I believe it was on the midterm, and people put that, yes, they could give permission, they could give informed consent. No, we're saying here they don't understand what we're saying. Yes, they're alert and oriented times 4, and we're just making gestures. We're pointing to body parts and trying to explain what's going on. No, they need a medical interpreter to translate, to make sure they understand what we're saying before they can give informed consent. Okay, another one. A client signed for consent for surgery, but during the surgery, you might remember this question, an issue arises. It's not an emergency, but it's another type of surgery they want to do while they're in there instead of him going through another surgery to have this done. They just discovered something. So what are they going to do? Are they just going to go ahead and do it? No, it's not an emergency. They're going to call the client's medical power of attorney or their next of kin and get consent. And then they're going to have 2 people witness, that they heard them give the consent and sign. They're not going to have 2 qualified medical professionals sign for consent. No, we cannot sign for consent for a client. We're not going to bring the patient out of anesthesia and explain the additional surgery. No, we're not going to do that. Okay, so this all explains that, of course. And again, these slides will be posted. And here's another one. A client signed the informed consent for surgery. You're talking with him to confirm he understands what the doctor explained to him, and he signed it voluntary. Then he says, I've changed my mind. I don't want to have the surgery. What should you do? You notify the provider. Do not talk to him. Don't even tell him that's your right to refuse. No, you don't say anything about that. You just say, let me get your doctor. And then you notify the provider about the client's decision. You don't be his advocate in this case and explain to him the risk of not having the surgery. No, the doctor does that. You don't advise him it's his right to refuse having the surgery. That sounds real benign. That might say, well, I should just do that. That's his right. If you do that and he doesn't have the surgery and maybe some families around, they overheard that and he dies. And then they say, the nurse told him he didn't have to have it. And yes, you did. You just said, you have the right to refuse that. You don't have to have that surgery. Don't open your mouth other than saying, I will get your doctor. Okay. Explain that he's nervous. No, don't do any of that. What comes out of your mouth and practice it is saying, let me get your healthcare provider. Let me get your doctor in here to talk to you. And if he starts asking you questions, can I refuse? Let me get your doctor. Be a broken record. Let me get your doctor. Okay. That's the only response. Okay. HIPAA exceptions. Again, we talked about this. Clients threatening self-harm or harm to others. You are a mandated reporter. You need to share that information with the police and whatever. So HIPAA does not apply in that case. And any elderly abuse or child abuse must be reported. You are a mandated reporter. And this, again, talking about mandating reporter. I'm trying to look at the clock here. We've got just a few more minutes. So abuse, nurses must report any suspicion of abuse, elder or child abuse, gunshot wounds, domestic violence, homicides, suicides, anything like that. Any patient abuse, if have a patient that's being abused physically or emotionally, or they're being neglected, or somebody's stealing from them, taking advantage, you are mandated to report that. Any communicable diseases need to be reported to the health department. Typically, if you're a staff nurse, that won't be through you. That will be through the physicians, the charge managers, not even the charge nurses, more like the managers or directors will give reports to the local health department, and they get those to the CDC then. Okay, mandatory reporting, again, dog bites sometimes. Well, we always reported dog bites in the ER. Sometimes it's other animal bites too. Impaired nurse, if you have working with a nurse and they are impaired, remember the impaired nurse compromises client care. Be sure that the problem exists and can be proven. Communicate specific concerns, what you saw, what you heard, what you observed, whatever. Document incidences in terms of behaviors, specific dates and times, be objective, file a report according to the hospital's or the facility's laws there, or their policies and procedures. And then occupational OSHA violations, make sure that you report any of those. You can report them. Typically, you would go, up through your hospital and say, hey, this equipment's not working right. And then if it's to the point where they're not taking care of it, then you can go to OSHA. It's supposed to be kept confidential so you don't get in trouble. And then sexual harassment, it's prohibited by state and federal laws. Follow your facility policies and procedures to handle reporting any complaints like that. Okay, and remember, you are mandated reporting, so do not keep any promises to somebody that says, don't tell anybody about this abuse, a child or a vulnerable adult or an elderly person, and they say, keep it quiet. You can't make them that promise. You can't keep the secret. You have to let them know. You do have to report it. You'll be there with them and help them report it. Community-oriented nursing. Okay, we need to get this done before you go because you will have a couple questions about this. Know the difference between community-oriented, community-based. Community-oriented, their goal is public health promotion and disease prevention, program management. Remember, we think, being in the office, they're taking care of these big programs for a lot of people. Focuses on communities and community aggregates and populations, a lot of people, screenings, immunization clinics, things like that, public health nursing. Now, community-based, remember, be with the patient. This is one-on-one care, pretty much. Yes, you can take care of families, but typically you're not dealing with these big communities. You're dealing with one person. Okay, goal is management of disease and illness. You're managing their disease they have. You're managing the illness or their injuries that they have. You focus on the individuals and families. And that can be like home health nurses, home hospice nurses, care managers, school nurses. You take care of the clients where they are. They take care of the children, in the school, one-on-one, help them with the asthma, help them with their diabetic shot, whatever. Occupational health nurses that work in the community, where they're providing care. And then here's a chart I just made up for you today to help you see what would be on the test. No, community-oriented nursing, especially their primary goal is to work with health promotion and disease prevention. They work with groups of people and with programs like public health nursing, program management for community based, again, be with the nurse. It's one-on-one usually. They work with clients. Home hospice nurse. Primary goal is management of illness, people that are ill, acute or chronic conditions, something that just happened to them, they broke a leg or something, whatever. Illness care, one-on-one. The client's home, in their home, acute or chronic. Wound care, somebody has COPD, somebody's recovering from a joint replacement, you're taking care of them, one-on-one, community-based nursing. And then we know the most commonly tested things about levels of prevention. Primary prevention is anything you do to prevent problems prior to them occurring. Examples, vaccine clinics. Memory trick, primary, prior to, prevent. And some people get confused about the teaching. Yes, if you teach somebody how to prevent something from happening, teach them safety or teach them healthy diets or teach them whatever, that is primary prevention. Okay, secondary is screening. Think of the word screening. Examples, mammograms, yearly physicals. So when you go to the doctors to get a checkup, even checking on something, that's screening. If you go to somebody's house to check to see that everything is safe in the house, you're checking their outlets, or checking, make sure they don't have cords running under their rugs, electrical cords or anything. You're checking. So it's secondary screening. It's early detection of things that could go wrong. And then the third one, tertiary examples. This is, think of treatment, tertiary treatment. They already have an issue. They already have an injury or a problem or an illness, and you're treating it. An example, low sodium diets, exercise, medication, and memory trick, tertiary treatment. And I also put teaching. Remember, teaching can be preventative, teaching these people how to not get diabetes by staying healthy and, and keeping their weight under control or whatever, or just teaching them about healthy diets. But here, if we're teaching somebody how to manage their illness or injury, or we're teaching them about a low sodium diet because they have hypertension, and so we're teaching them that is tertiary teaching, okay? Here's preventative teaching. They don't have an illness or an injury, and you're teaching them how to stay healthy. Here, you're teaching them they already have it, but you're trying to teach them how to manage their illness. And then here was an example that we used about neonatal abstinence syndrome, when the babies are born addicted to opioids. So primary prevention would be that we prevent, help them prevent pregnancy, to prevent addiction from occurring too. And secondary prevention would be if we're screening just all these pregnant women to see if they have, if they are testing positive for opioids. So we want to do that during their prenatal visits. And then tertiary treatment means we're treating them. They are addicted. They are delivering the babies that are addicted. So we want to treat the women and treat the babies. So that's how it applies to this situation. So make sure you review that. And here's a question. I know we're 1 minute over, but I think I've only got like 2 slides. So let's do this. And if you have to log off, you can look at this in the video. But a community health nurse, and I would highly recommend you know the answers to these. Community health nurse is informed by a client that a tornado touched down in the community, which the nurse works. Mass casualties have occurred. Which of the following actions should the nurse take first? Follow the community nurse health care policy. And yes, remember, we already did that. I think I put that in there twice, sorry. And about the train collision, we're worried about the person that has epigastric pain and left arm pain. I'm sorry, we put that in there. I didn't realize I had those questions in before. But here we have our disaster again, and you will have a question. You will have 5 questions on this, on the exam. And you need to identify people. So here's an example, and I am going to go through these if you want to hang on. If not, it will be in the recording because you will have to answer almost identical question to this. What are the tag colors indicated? And you'll have to tell me what color you're putting on each. So a 40-year-old man who has cuts and abrasions to the chest, as well as a puncture wound to the upper right chest. He's having difficulty breathing. Is this somebody that has life-threatening injuries? Anybody want to volunteer? What color would we give him? Green would be minor injuries. He's having trouble breathing. He's got a wound in his upper right
Oh,
chest.
sorry, I meant red.
Okay, yes, red, immediate life-threatening injury. So we would give this guy red. The best thing, if you get test questions, find the one that's the worst and give them red, and find the one that is dead and give them black, and then you can work out the others in between. Okay, but so here's a 30-year-old man with possible fractured right forearm. He's holding it with his left hand as he walks around looking for his family members. What would we give him? How would we classify him? I'll go through it quickly for you.
Green.
Green, yes, thank you. Green, he's got minor injuries. Yes, it's a fractured forearm. He's holding it though he's walking wounded, you know. We do want to keep an eye on him, make sure there's nothing else going on, but he's green. We're going to pass him by for now. 25-year-old woman who's unconscious. She has agonal breathing, barely breathing, about 6 breaths a minute. What appears to be very
Gray.
severe head wound. What would that be?
Gray.
Gray,
black.
that's right, because she is breathing. She's still alive, but she is not expected to live. She's dying. Okay, great, good job. Teenage boy who's not breathing, has no pulse, has a piece of metal impaled in his neck. What would we give him?
Black.
Yes, black. He's dead. Okay, not breathing, no pulse. And that only leaves one color. 40-year-old woman has a possible compound fracture of her left femur. Femur fractures are pretty serious. You know, you can bleed a lot from that. She's crying, breathing without difficulty, is holding her rolled up sweater over the wound, applying pressure. She's significant injuries, but they can wait about an hour. She's delayed here. She is yellow. This, the red one is more severe. They are having difficulty breathing, okay? So that's what you're going to have to do on the test is come up with 5 patients very similar to these, hint, hint, and identify what tag you're going to slap on their wrist. Nurse is planning a teaching session at a community center about preventing suicide. I think this is the last question. Which of the following groups should the nurse recognize is the most at risk for suicides? Do you remember from our lecture? It was a few lectures ago. I'm just going to tell you because of time. Older adults, believe it or not, are typically at higher risk for suicides. I know we have trouble with children anymore and social media upsetting them, adolescents, middle-aged people go through things too. You know, everybody does, but there is a higher risk of suicide in older adult male clients, age 75 to 90. The actual statistic is in elderly, period, man or woman, that is considered over 65 years of age. Okay, so if they've picked an adult male client in this range, age range, yes, they meet that criteria. So that is it. Study well for the final exam. You know, look through the slides
Thank you,
again,
Ms. Brenda.
listen to the lecture. What was that?
Thank you.
You're welcome. And be sure and email me if you have any questions. And if you go through this slideshow again, or if you're taking good notes, you should do very well on the final exam.